Good afternoon, everybody. I am Dr. Shashidhar from Bangalore. I thank Dr. Ashish sir and team AMC for the invitation. So I am very glad to be in this place, which is known for its immense knowledge of Patliputra. I'm really glad to be in this place. So today my topic is total flexion deformity in total knee replacement. So this is one of the commonly seen deformity in the advanced osteoarthritis of the knee. Many patients who require knee replacement will have some sort of moderate flexion contracture, and this is generally fully corrected at the surgery. So as per reports, the presence of fixed flexion deformities has been reported in up to around 61% of the patients who undergo knee replacement surgeries. And the complete correction of this deformity at the time of surgery is generally challenging and technically demanding. Okay, what really happens here? Here there is a soft tissue contracture along with the bony hibernation, and there is a tethering effect of the osteophytes on the ligaments and on the posterior capsule of the knee joint. So the flexion deformity, it reduces the tibiofemoral contact area. So this accelerates the degenerative process by increasing the stresses across the knee joint as the forces are distributed over a smaller area. So the net effect of this deformity, it manifests as one, as a stretched anterior skin. There is a tight posterior capsule. There is lax anterior structures, mainly quadriceps, because of the prolonged flexion deformity. There can be loss of posterior femoral condyles, tibial condyles, and a thinned out patella because of the constant pressure. The muscle spasm and the periarticular pain also increases the deformity further. So prolonged flexion deformity, generally more than 40 degrees, it decreases the ability of the patient to walk, and generally, ultimately, it results in disused osteoporosis and a weakened bone at the time of presentation. In primary osteoarthritis, it is mainly of a posterior soft tissue contracture and osteophytes. In inflammatory arthritis, there can be associated posterior femoral condyle erosion as well. Okay, how to deal with it? So the most important part is the removal of the osteophytes and the soft tissue releases. So once we are doing this, generally we end up having a flexion gap, which is more than the extension gap. To manage this, we have got two options. Either you can increase the distal femur cut, or you can upsize the femoral component. Okay, let's start dealing one by one. One is the measured resection technique. Here, the distal femur and the proximal tibia are taken as per the jigs, as per the company's jigs, whichever you use. And then the equalization of the gaps is done by the soft tissue releases and removal of the osteophytes alone, and not by revising additional bone cuts. So as we can see here, the removal of the posterior osteophytes and significant soft tissue release posteriorly. Now coming to the extra distal femoral cut. What they say is, in general, for every 10 degrees of flexion contracture, additional of 2 millimeter resection can be done with a maximum of 4 to 6 millimeters. The advantage with this is the larger deformity can be corrected along with the soft tissue balance. Will balance the increased flexion gap because of the removal of the osteophyte and the posterior soft tissue release. The disadvantages, there will be joint line elevation and there can be patella baha, which can lead to decreased flexion. Now coming to the equalization of the gaps. As we discussed, there is a higher probability of flexion gap being more than the extension gap. So this can be either managed by an extra distal femur cut or upsizing the femoral component. Now coming to the upsizing of the femoral component, as you can see from the image, it will decrease the flexion gap. We can as well decrease the posterior slope of the tibia as well. The upsizing of the femoral component is limited probably by 1 or 2 sizes depending on the company which you choose, and the large gaps cannot be, large flexion gaps cannot be managed with just upsizing 3 sizes or 4 sizes up. A constrained implant should be used if there is a coronal plane instability which occurs because of a significant mid-flexion instability which may occur, which generally is seen when there is a over resection, which may lead to a significant mid-flexion instability. This is generally encountered when there is a gross flexion deformities. Always, when we correct the significant fixed flexion deformity, we have to keep a watch on the distal neurovascular structures, because these are the complications are well known. Now coming to the post-operative care, so generally they need a knee immobilizer for 3 weeks with intermittent physiotherapy, and then as a night splint of knee brace for another 3 months. With a patient with a severe fixed flexion deformity, where there is a residual probably more than 20 degrees of FFD, they will need a pushed knee splint for a longer duration of time. And rare cases may even need serial casting to maintain the correction. I will end by 2 small cases of mine. Here there is a varus with fixed flexion deformity, where you can see a lot of osteophytes posteriorly as well, a bilateral thing. So I managed it. The patient was walking like this. As you can see here, I have upsized the femoral component on both the sides, and since there was a significant defect on the right side, I have used an augment. On the left side, I have used a screw and a graft and screw with a stem. So this was the patient before surgery, and this is around 2 months post surgery. And the second case is a Valgus F50. So this patient is 68-year-old. She came to me with a bilateral fixed flexion deformity. She was basically bedridden for the last 3 to 4 months. And as you can see in the lateral view, there is significant osteophytes are there on both the sides. And she also had a stress fracture lower down in the tibia. So I managed this with a of course, here the distal femur cut was increased, and for the stress fracture, because the stem could not pass beyond the stress fracture, I have put an additional plate over there. And on the left side, there was no stress fracture below, so it was managed with a regular. So this is 6 weeks after both the knee replacement being done. Thank you.
Thank you, Dr. Shashidhar. That's a wonderful talk. Any questions by the time next talk is being loaded? None, I think. Okay. Do you give any traction before, suppose? And what about if the hip and knee both are involved? What's your preference?
Hip, always do the hip replacement first. Yes.
And what's the time gap between the hip and knee?
Minimum 6 weeks.
Minimum 6 weeks. Okay. Thank you very much. Okay,
Thank you.
Thank you. So for the next talk on revision knee replacement, all aspects, Dr. Mrinal